Good afternoon, everybody. This is Dana Harganani with the Oregon Health Authority, and this is our COVID-19 webinar series for healthcare providers put on by the Oregon Health Authority. I want to start with introducing who's joining me in the room today, and then we'll go through our agenda for the day. Also, key presenters include those listed on the slide, Tom Jean, Ariel Smits, Kat Livingston, all physicians and epidemiologic experts in the room. Also, I will let you know that we have Paul Cieslak and Katrina Hedberg, also physician and epidemiology experts with us in the room, who will be helping out as well along the way. So we have a lot of expertise, and our intent is to keep you with efficient and clear information that you've identified a need for regarding to COVID-19 as you do the important work you're doing on the front line. I will have everybody, when they are speaking, to go ahead and introduce themselves personally, so you can share your role specifically within the Oregon Health Authority as you're speaking. So our agenda for today, I will just start by sharing an introduction to how we're going to manage this webinar. We are going to spend a lot of time providing Q&A related to questions that you have posed to us over the last week and at last week's webinar. So some of this information will be provided verbally to you. We will send you to published guidance documents where they exist. Much of this information is already posted. And then we will have some slides that have a little more detail of information, and we'll work to send this out to those who have registered for this webinar. So the topics we intend to address today include an overall update on COVID-19 and general information about the coronavirus, updates about testing and answers to your questions, also related to personal protective equipment, clinical facility-specific information. We will also spend some detailed time talking about current status of telehealth coverage, some more information about the needs and new policies around healthcare workforce, and we'll close with discussing briefly about policy changes and surge preparedness. We are not going to be able to answer your questions real time today during this call. We hope that our Q&A that we're offering will already address many of them. We do invite you to go ahead and continue to put your questions in the chat box feature. While we will not be answering them real time, we have been collecting those and informing that for our next webinar opportunity with you. Moving forward, I will first just share an update of the COVID-19 pandemic as it relates to Oregon. And this is data as of this morning that OHA has reported. So currently we have 209 positive COVID-19 cases. These have had a positive test in our state, either through our state public health lab or through a commercial lab that was then reported to us as required. We have a total now of 8 deaths in our state, 4,300 negative tests or so. And I just always want to remind you all that the 209 positive tests is not reflective of the full impact of COVID-19 in our state. As we've shared before, we know that community transmission is broader, and that testing capacity has been limited. We'll get to a little more detail about the overall status of COVID-19 beyond this testing slide. Okay, so we're going to move into some of the answers to the questions we've collected, and I am going to start by inviting Dr. Jean to introduce himself and start with some general information about COVID-19.
Thanks, Dr. Harganani. So this is Dr. Tom Jean. I am a Deputy Health Officer and Deputy State Epidemiologist at the Oregon Public Health Division, and I've been one of the Senior Health Advisors for our COVID-19 response. So I'm going to start by going through some of the general questions about the virus and the epidemiology that we received, and try to address those as best we can. So the first question was about asking about estimates for how many undiagnosed people, what's the true prevalence of COVID-19 currently, in the wild. So the answer is, of course, that testing is limited. We've had testing issues in the U.S. from the start here, so we don't have a really good estimate right now. So there's a lot of modeling that's been going on to try to get to that. The current U.S. case count is just about 50,000 cases and 615 deaths, but again, that is surely an underestimate. There were some Columbia University researchers who estimated that about 650,000 people in the U.S. might become infected in the next 2 months. And then some CDC modeling estimates that over the course of the entire epidemic, hundreds of millions of people could be infected in the United States. There's a wide range of scenarios there. So again, no hard numbers. This is all modeling, and the assumptions of the models are going to be pretty important for their accuracy. But the thing that is certain is that there are a lot of undiagnosed people out there. The incubation of the virus, the incubation period is 2 to 14 days with a mean of 6.4 days. And the next question was, how long do infected individuals shed the virus? So there have been reports of viral shedding for weeks after the illness. And the virus can be detectable by PCR for quite a while after recovery. 37 days, Paul's saying. So, but one thing to point out is that a PCR detection of viral RNA does not mean that the virus is viable, and we have not heard a lot of reports of confirmed transmission after people have recovered. So our recommendations are for people to self-isolate until 72 hours after they have recovered from both fever and cough. And that's just based on our best recommendations on preventing transmission. And that's similar to the CDC's recommendation, not exactly the same. In terms of reinfection, there have been reports of reinfection. It's really not clear if these really represent an actual reinfection versus continued infection. And with a new virus like this, it's going to take a while before we have a hard answer on that. There was another question about the rate of co-infection with influenza. And I've seen 20%, up to 20% co-infection reported. And then in terms of our current influenza rates, we had 12.5% of influenza tests positive during the week of March 8th to 14th in Oregon. And so we've seen a little bit of a spike in influenza cases lately, but that's maybe due in part to increased testing for influenza because of the COVID-19 outbreak. Another question was about getting into a couple of pharmaceuticals here. Safety information on the use of NSAIDs, non-steroidal anti-inflammatory drugs, with patients with possible or confirmed COVID-19. There have been reports that such anti-inflammatory drugs could worsen the illness, but there's really no scientific evidence. FDA does not have any statements on this, and based on the currently available information, the World Health Organization does not recommend against the use of ibuprofen. And the next question is on chloroquine. Both chloroquine and hydroxychloroquine have been proposed as treatments for COVID-19. There's a lot of interest in this. There's not. The short answer is there's really no data to support the use right now. And Dr. Paul Cieslak is going to add a little bit on that.
Yeah, much is being made of a French study that has been sort of pre-peer review published as just a Word document, and you can find it online. But basically that study has a number of what I would call serious limitations. They had 42 patients. It was an observational study. They weren't randomizing them. They were just looking at patients who had been given hydroxychloroquine and patients who had not been given hydroxychloroquine in France. They were from 4 different cities. The exclusion criteria included, well, they analyzed the people who had been given the drug against the people who hadn't been given the drug, and people could voluntarily not get the drug. All of the drug was given in one city, and they compared results from the people given the drug in that one city to people from 4 cities who didn't get the drug. They started with 42 patients and then weeded out 6 of them, all in the hydroxychloroquine group. And if you look at why they weeded them out, well, 3 of them went to intensive care. I think one of them died, I believe. One of them, I think they couldn't find afterwards. And so, they don't have complete follow-up on all their cases. It wasn't exactly an intention to treat analysis. They did not look at clinical findings. The benefit was reduction in duration of nasal carriage of the virus. So they weren't looking at, did people leave the hospital sooner? Did they get out of the ICU sooner? Was there a reduction in mortality? They weren't looking at any of those data. Add to that the fact that chloroquine prolongs your QT, hydroxychloroquine prolongs your QT interval, and they were noticing a synergistic effect on this viral shedding with azithromycin, but that also prolongs your QT interval. And I'm not sure we want to give both of those drugs to large numbers of people on the suspicion that they have COVID-19. So we're not, we're following the research with interest, but we're certainly not making a general recommendation for its use.
And there are concerns of shortages for patients who are taking hydroxychloroquine for RA or other rheumatological conditions. And I know that OHSU just issued a recommendation or directive against prescribing hydroxychloroquine for COVID-19 in most cases.
Yeah, and this is Katrina Hedberg, and I got a hold of our colleagues at the Board of Pharmacy, and they're actually going to issue an emergency rule related to prescribing chloroquine for basically outpatient settings, et cetera. You have to have an ICD-10 code. In other words, if it is for rheumatoid arthritis, the pharmacist would fill it. If there are inpatients who are COVID positive and they're in the hospital, it could be considered. We're clearly not recommending that for all the reasons that Dr. Cieslak just mentioned, but to be aware that the Board of Pharmacy is going to prevent pharmacists from filling outpatient prescriptions for people who are trying to take or thinking about taking chloroquine as a preventive measure. And we'll send the link around to that Board of Pharmacy emergency rule, so they won't fill it, but we would, of course, appreciate that providers not even prescribe it in the first place.
Great. Thank you, everyone. We're going to move on to the next topic around testing for COVID-19. Again, Dr. Jean is going to cover some of the questions that we received over the last week with some responses.
Great. Yes. So moving on to testing, everybody should know that we did just update our testing guidance for healthcare providers, and that is available on our website. The short link is healthoregon.org/coronavirus-HCP. The link that's on the screen right now will take you to, I think, Kate Brown's coronavirus page, but it's healthoregon.org/coronavirus-HCP. And that gives you all the guidance, including healthcare guidance. It has infection and clinical care, infection prevention guidance, as well as the testing guidance. And that testing guidance, as I said, was just updated. So the important highlights are that clinicians can order COVID-19 testing, the coronavirus testing, at their discretion through clinical labs. And Oregon hospitals, several Oregon hospital labs are now doing in-house testing, I know. And then there are commercial reference labs like LabCorp and Quest Diagnostics. So clinicians don't need to obtain approval or notify us in public health prior to that testing. That is all at their discretion. We do not need to be a gatekeeper for that at all. And then we do have the recommendation that during, while influenza is circulating, we would recommend that influenza tests be completed and determined to be negative prior to ordering COVID-19 testing. And one exception might be if the patient's not eligible for oseltamivir due to timing or other reasons, then you could defer influenza testing to conserve swabs. So general recommendations, symptomatic patients only. And that would include patients with fever, cough, or dyspnea, healthcare workers. And the high risk, the high priorities for testing would be healthcare workers, patients with worsening symptoms, patients who are older than age 60, patients with underlying medical conditions, including hypertension, diabetes, cardiovascular disease, lung disease, and immunocompromising conditions, pregnant women, And then finally, patients who had contact with a suspect or lab-confirmed COVID-19 patient, or who had traveled from an affected geographic area. That's kind of a holdover that still applies in the setting of community spread. So I went through that list fast. Those are all in the testing document for commercial labs. Secondly, the state public health lab is doing testing, and we do need clinicians to get approval from us prior to those tests going to the state lab. And we are focusing on two groups: hospitalized patients with viral lower respiratory infection and a negative flu test, and number two, symptomatic individuals who work or reside in a high-risk setting, such as a long-term care facility, a correctional facility, or other congregate living settings. And again, I want to highlight that asymptomatic people and those with mild symptoms that don't necessitate medical evaluation are not recommended for testing. Those people should remain at home for 72 hours after any fever or cough resolve. And the reason for that is people with mild COVID-like illness who seek testing are, number one, potentially exposing others in healthcare settings, including members of the public, other patients, healthcare workers, and that evaluating and testing these people consumes resources that may potentially be extremely limited, including PPE, swabs, and it also ties up clinical resources, including healthcare staff and rooms. So that is our strong recommendation. Okay, moving on to a question about how to order testing kits. I would say work with your clinical lab or directly with the national commercial labs who can supply the test kits for collecting specimens. Our state public health lab has a very limited stock at this time, and we're not able to stock providers or healthcare facilities. We're sending all our kits to local public health and tribes and correctional facilities. Turnaround time of the tests. Currently, we have heard from LabCorp that the turnaround time is 3 to 4 days. And then our state lab is reporting a 3-day turnaround time after they receive specimens, although currently they're running a little ahead of schedule, but three days is their stated turnaround time. The next question was about where can we send patients to get testing, i.e. for sample collection, and what about for commercial labs? So generally testing should be done in a healthcare setting only for symptomatic patients according to your facility's protocols. And we have been saying that if a patient does not have a clinical need to be sent to an emergency department or a hospital, do not send them there just for testing. In terms of healthcare workers, it's up to employers to make testing available to their healthcare workers as needed. And then about commercial labs, the commercial labs by my understanding, are not allowing any walk-ins to their sites for COVID-19 testing. The specimen should be collected by a healthcare provider or a public health authority. Next question, sensitivity and specificity of the testing. So this is a very good question. In some of the early Chinese studies out of China, they found that oropharyngeal swabs the SARS-CoV-2 RNA, that's the COVID-19 virus, was detected in only about 32% of the OP swabs, the oropharyngeal, whereas it was detected in about 63% of the nasopharyngeal swabs. And I think that's one of the reasons that CDC and our US recommendations have been focusing on the NP swabs. But NP swabs could miss an early infection, and so the ideal swabs would be, lower respiratory specimens, but obviously those are not feasible for all patients. Let's see. So we don't really, one of the problems with assessing sensitivity and specificity is you really need a gold standard. And at this point with a new virus, we don't really have a gold standard to compare against. So the actual sensitivity and specificity of these tests is really up in the air for that reason. We think the PCR is pretty good, but again, if the specimen you're collecting is from an area that doesn't have great sensitivity itself, then it doesn't matter how good the PCR test is. There was a question about new FDA-approved rapid testing. And so what I can say about that is on March 16th, the US government took a pretty unprecedented step towards increasing access to COVID-19 testing by allowing developers of certain tests to commercialize their tests without even the requirement for FDA emergency use authorization. And so as a result, numerous companies are now developing COVID-19 testing, including point of care tests and serology tests, which would be tests for antibodies, including IgG and IgM. So these may come online pretty rapidly. I'm aware of some that are apparently already available, but trying to figure out how good these tests are and what their true sensitivity and specificity are is going to be important, given the limited oversight and the speed at which they're being developed. I've looked at one technical document for one of the serology tests, and it reported a very high sensitivity and specificity. But again, I'm still waiting to hear what their comparator was. And they also reported cross-reactivity potentially with some non-novel coronavirus strains, which is obviously a concern as well. So our OHA medical and lab experts are going to be meeting in a couple days to review these tests that are coming online and try to get a sense for how good they are and what's really available. Okay, moving on, let's see. There was a question about antibody testing, and that's kind of what I just mentioned. There are serology tests coming online, and that'll be very helpful. It would be great to know if a healthcare provider, for example, has immunity against COVID-19 because they've already had the virus. The serology could demonstrate that. There's a question about how much will patients be charged for testing, including Oregon Health Plan patients. In general, most insurers in the state are waiving costs for COVID-19 testing and the associated visit. And there's a list of insurers available from the Department of Consumer and Business Services website. And then Oregon Health Plan is also one of those insurers.
And we'll be posting the website link to the DCBS information. That includes both telehealth coverage information as well as testing coverage. So stay tuned, we'll point that out on a future slide.
And then the last question here on testing was, is there any combination of symptoms or lack of symptoms to help guide testing advice? And again, I would just highlight the primary symptoms for COVID-19 that we are concerned about are fever, cough, and dyspnea. And we don't want asymptomatic people to be tested.
This is Dana Harganani again. I'm going to put a question on the table in the room for the experts. One question I have been hearing about the risk of co-infection with influenza, and so with the recommendation to test first for influenza, would we potentially be missing people who then don't subsequently get tested for COVID-19? Does anybody want to comment on that?
This is Ariel Smith. I've heard case reports of children with co-infections, but that's the only information that I have.
Yeah, I think it's entirely possible. We don't know the rate at which co-infection with influenza will occur. I've seen more data on co-infection with COVID-19 and other respiratory viruses, but it wouldn't surprise me at all. We definitely want influenza testing to continue because, first of all, near as we can tell from our limited data, it's more prevalent than COVID still in Oregon, and it's treatable. So you're looking for something that you can treat. So in general, if somebody presents with influenza-like illness, like fever and a cough, I would argue that you should be testing them for both.
Great. So again, just for you, anybody who's joined us, we are going through responding to questions that we've been receiving either from the last webinar or over the last week. So I'm going to now pass it over to Dr. Ariel Smith, who's going to talk about a couple questions that came up on personal protective equipment. I will note that a little bit later on, I'm going to be talking about work that's underway, both related to the executive order that Governor Kate Brown put out regarding elective procedures and PPE. So I'll speak to that later. These are some more clinical specific questions on PPE.
This is Ariel Smith. I am the medical director of the Health Evidence Review Commission, and I'm one of the senior health advisors on the COVID project currently. The first question that we received was what procedures cause aerosolization? There should be on your webinar, if you have the slides available, there's a limited list of basically things that go into the lower airway: intubation, extubation, CPR, tracheostomy procedures, bronchoscopy, surgery and postmortem procedures that involve high-speed devices. There's some dental issues, possibly involve, that might get into the airway. BiPAP and CPAP, so your non-invasive ventilation procedures, high-frequency oscillating ventilation, high-flow nasal oxygen through a nasal cannula, sputum induction, nebulizer treatments, aerosolizing generating procedures. Those all count as aerosolizing generating procedures. When you do an aerosol generating procedure, you should have both standard contact and airborne procedures, including eye protection. So N95 mask or better, eye protection, gloves, and gowns. If available, the patient should be in an airborne isolation room. And for 2 hours after the procedure, there should be no use of the room. The next question about personal protective equipment was, is it safe to reuse? There is no specific guidance on use or reuse of PPE. If you have a cohort of patients who are all proven positive, it's generally considered by OHA to be okay to reuse the same mask and eye protection as long as you do not touch them. But if you are going between patients who are positive or rule outs or other, you should be removing any PPE. But this is a rapidly evolving area, and we will hopefully have more guidance coming.
Yeah, and one thing, this is Dr. Jean, one thing I would add is, if you have PAPRs and some of the more typically industrial respirators are obviously reusable and disinfectable, whereas we're not sure yet if an N95 mask can really be disinfected with either UV or other, or chemicals and still maintain its integrity. But there are, PAPRs and all those other types of respirators are something that have potential to be reducing our shortages because they are reusable and disinfectable.
Great. We do hope and expect for ongoing information on this topic to be upcoming. Okay, back to our list of questions and answers. We're also going to respond to a couple questions that came out about specific clinical and facility information. So Dr. Schmitz?
So there was questions about skilled care facilities, about what to do if you have a patient with presumed or proven COVID. The recommendations are, you can find them on our website, with Dr. Jean had pointed out the link, and you'll get that at the end of this presentation as well. But basically, try to limit the number of staff interacting with any patients with respiratory illness, limit the number of staff like wound care nurses who have contact with a large number of patients. Ill patients should be cohorted, so either put them in single rooms with private bathrooms, or you can put, if more than one patient is proven to be positive, they can be cohorted in a room together. Do not transfer ill residents or residents with known exposures to unaffected units. And if they must leave their room, residents should wear a face mask or other type of, if they can't tolerate the face mask, some other tissue or other thing to cover their nose and mouth. And if you have a confirmed COVID-19 case in your facility, limit the activity and movements of all residents, restricting them to their rooms and practicing social distancing of at least a 6-foot distance. And then then there were some general questions about general primary care. At this point, the recommendation is for non-urgent primary care services, try to conduct as much as possible via telehealth, which would either be video or telephone, and try to delay non-urgent care of patients out 6 weeks if it's clinically reasonable. There was another question about guidance for chiropractors. And again, the same guidance as for primary care. In general, all non-urgent outpatient chiropractic procedures and visits should be delayed if this is clinically appropriate.
Let me just add one thing. Yeah, hi, this is Paul Cieslak. Let me just add one thing, and that is, if you have a couple of cases with undiagnosed influenza-like illness in a long-term care facility, please report it to your local public health department, because we would want to undertake an investigation. Again, you should be testing these people for influenza because you can do oseltamivir prophylaxis for non-ill residents and of course treatment of the ill people. But this is a high priority group for us to test for COVID.
Great. And one more time, at the end of the slideshow, there is the web link that will be more accurate. And there's specific guidelines now posted on our website about long-term care facilities. So please make sure if you're involved in that care that you take a look at our current guidance up on the web. Okay, we are going to move on now to telehealth coverage. We know this has been a very active area of, I guess, policy development and information gathering. So we're going to have Dr. Kat Livingston provide an overview, and I'll chime in with some information as well. So you want to introduce yourself?
Sure. So this is Kat Livingston. I'm the Associate Medical Director of the Health Evidence Review Commission. And I'm getting closer to the microphone, despite with still regard to social distancing. So in terms of telehealth coverage, I'm going to focus on the Oregon Health Plan. This is obviously an actively evolving area, and I think all of us are becoming intimately familiar with telehealth in a way that we were not before. So starting March 13th, the Health Evidence Review Commission adopted a new prioritized list that had a revised guideline note 8.5, which addresses telehealth, teleconsultations, and electronic and telephonic services. There's also a statement of intent, which is specifically regarding telephonic services during an outbreak or epidemic. And the intent behind this is really to suggest decreasing administrative barriers and supporting changes to things like reimbursement in times of COVID. You can find the actual prioritized list language at this website. There's a searchable function, and you can put in telehealth and find these if you want to look at the specific details. And again, a reminder that further guidance from the Oregon Health Authority and DCBS will be coming out for the Medicaid health plans, the coordinated care organizations, as well as for commercial insurers. And I believe that those are coming out today.
Yes, and I'll speak to a little bit more about that before we leave this topic.
Okay, if we can do the next slide. So I'm going to focus on the Oregon Health Plan coverage of telehealth visits. Again, this went live March 13th. So there are several different categories, as all of us are becoming very aware. There's the synchronous video and audio, which is the classic telehealth. So this is a visit with a provider in which you interact in real time, and it's supposed to ideally be through a HIPAA compliant system. The federal authorities have let us know that they will not be enforcing the HIPAA compliance issues, and that other services such as Skype and FaceTime are acceptable during the epidemic. There is a link that you can see with footnote number 1 that addresses this planned lack of enforcement around the HIPAA issue. There are a lot of different codes that can be used for telehealth. So this would be all of your normal visits, behavioral health visits, inpatient codes, and those are all appropriate for use for the synchronous audiovisual telehealth visit.
For anybody who's wondering about the slides, we will be sending them out to those who registered, so don't have to feel like you're frantically writing any of these codes down.
Yes, and they are available in the prioritized list guideline as well, so you can pull up that guideline on the searchable list and you can see all of those codes in great detail if you would like to see them. There is a specific code Q3014 that can be used if the patient is in a healthcare site, but otherwise this can happen with the patient at home and the provider wherever the provider needs to be. One of the questions was, can the provider deliver this through being at home? And there are no specific restrictions about that. The patient can be at home or in the hospital. However, the patient must be in Oregon. And so this kind of telehealth can be used for inpatients, outpatients, new patients, established patients, anybody. I assume everybody's using this a lot. In terms of e-visits, so these are considered asynchronous electronic visits. So this might be, for example, many Oregon providers use Epic. So this would be a MyChart discussion that could happen over the course of a week with a back and forth with a patient, or other electronic health record-based patient portals. So you can see there are a series of codes here that are appropriate for use, and that they vary depending on the provider type. For the Oregon Health Plan, these are limited to established patients only. Some commercial payers are waiving this requirement under these circumstances. These also must be patient initiated. So certainly letting your patients know that these services are available through sort of these detailed asynchronous electronic visits, but that one cannot bill for that unless the patient initiates the service and initiates that as an encounter. It's also important, not for OHP because there is no cost sharing, but for commercial insurers to ensure that the patient is aware that there may be cost sharing if using these particular codes. Again, for OHP, there is no cost sharing. Telephone only visits. So this is just having a conversation on the telephone. There's no video involved. There are codes for this that are both for physician or equivalent or non-physician codes, and those are provided for you on this table. This is also for established patients only, although some payers are waiving this requirement under the circumstances. And that further guidance from DCBS and OHA is going to be available today. There's another code specifically addressing a quick virtual check-in. This can be by phone or audio video connection. So this is kind of a combination of both. It's only 5 to 10 minutes. There's a specific code, and that's also allowed just for established patients only. And the final category in this telehealth world is the clinician-to-clinician interprofessional consultation. There are a series of codes, so this includes things like e-consults or having a telephone call. And this can happen in the inpatient, outpatient emergency setting for new or established patients. So again, the situation is actively evolving. There may be guidance that's going to vary by the various different plans. The fee-for-service team for the Oregon Health Plan is still working on detailed guidance, and here are a series of websites that will help address some of the details. I think the Medicare fact sheet is particularly one to also look at, as Medicare has taken a somewhat different approach and somewhat more restrictive approach than what, for example, the Oregon Health Plan has done. But there's a lot of guidance in there that talks about the HIPAA waiver and things like that that's of interest.
Great. So this is Dana Harganani again. I mentioned that I would be providing a little bit more information as it relates to further guidance forthcoming. This has been work underway acutely over the last week or so, and we expect this to be posted. So I will give you a preview of what this is. And again, I anticipate it will be posted both at OHA and DCBS forthcoming soon. So this guidance is from the Oregon Health Authority and the Department of Consumer and Business Services. Already you have heard from Dr. Livingston, work that's already been done in terms of coverage on the prioritized list of health services for Oregon Health Plan members. The guidance that I'm speaking to is more specific to both commercial insurance and Medicaid health plans like CCOs specifically. So just to give you an example of some of the guidance, it includes that health plans shall cover telehealth services delivered by in-network providers to replace in-person visits whenever possible and medically or clinically appropriate. And it's recommended that providers shall be allowed to use all modes of telehealth delivery, such as Dr. Katz Livingston just provided an overview for OHP specifically. It also is, again, the guidance is that telehealth services shall be available for all conditions, not just those specific to COVID-19 or suspected COVID-19 cases, again, with the intention to get people out of the physical clinical sites to reduce the spread of COVID-19. And further guidance will be forthcoming. This is, again, just about to be posted. Another couple points that will come out of this guidance document: health plans shall examine reimbursement rates for telehealth services to ensure they are adequate to enable providers to increase capacity to serve patients with appropriate telehealth delivery methods. And health plans shall ensure cost sharing requirements for services are no greater than if the service was delivered through in-person settings. And then finally, I'll just note again that health plans shall clearly communicate to their members and provider networks about options to receive healthcare services. So again, so that this has become more publicly available, so you all know that information. So I'm not going to go further because this document has not yet been posted as far as I know, but should be by the end of the day. I believe if you check the DCBS site, that is where you will see this guidance as listed here under the Division of Financial Regulation. So more to come. We know this is an evolving situation. The information hopefully today under OHP and the billing codes and coverage should be a really foundational source of information, with further guidance coming to the broader insurance plans across the state. and hopefully that will be updated soon so you have more access to up-to-date information on what that guidance and coverage looks like. Okay, a couple comments here. We got some questions about healthcare workforce inquiries on our last webinar. We're going to just keep this high level. There were quite a few people that were asking further about if they could, where do they go to sign up to help if there was a need for further healthcare workforce to address COVID-19 surge, particularly in our state. And the answer is yes, there's a need. Our recommendations, if you already work for a healthcare organization, or a hospital, you're likely already hearing from those groups on preparing kind of their surge capacity. So I would encourage you to reach out to your organizations if you haven't already heard to see how you might be able to step up to support the expected increasing number of patients in Oregon. If you are not connected already with an organization that could be that source for you, we do recommend that you sign up for our Serve-Or, so our statewide emergency registry of volunteers in Oregon. This is a website contact here, and it hopefully should be an easy way where you input information about your licensure, etc. So please do go check out that site if you are interested. We will be using this and already are to identify potential workforce to help us as our capacity gets strained in the coming weeks. I would also alert you that the Oregon Medical Board just updated some emergency changes around supporting the capacity of workforce needed for surge in Oregon. I don't want to speak to this in detail because I'm not an expert, but this relates to changes about whether providers who are licensed out of state and whether they can be serving this need in Oregon during COVID-19. So you will see information there about that, as well as quick opportunities for updating your licensure if you're recently retired, etc. So there's more information at the Oregon Medical Board as listed here on their COVID page. And this is hot off the press since yesterday, so I don't want to speak to it in detail, but we encourage you for licensees under the Oregon Medical Board, or could be, please go visit the site and find out what the information is. This is one more slide about Serve Oregon. Again, this is for licensed healthcare professionals in Oregon. Just a little bit more information where you can find out about Serve-Or. We have a lot of people signing up, which is great, and we absolutely intend to utilize that information to organize our workforce when we know we're going to be building out new capacities to address forthcoming hospitalizations that we expect and need to offload hospitals for patients who could be served in another alternative care setting, especially step down or addressing other acute care needs where we need to keep the space open in our hospitals. So please do consider volunteering if you are interested. Just a couple updates. Again, to orient you to information that will be published soon. As you know, there's been a lot of policy changes happening across the state, led in part, some of course from our governor's executive orders and directives, and others updated from the Oregon Health Authority. We have been getting quite a few questions about the executive order that Governor Brown issued on March 19th related to canceling all elective and non-urgent healthcare procedures that require personal protective equipment effective yesterday, March 23rd. I will just say that we are just about ready to post an FAQ about this specific executive order because we are getting a lot of questions. And I just want to say at a high level, procedure is subject to cancellation if it is elective or non-urgent and the procedure requires the use of PPE. A procedure is exempt from cancellation if delay would put the patient at risk of irreversible harm. And this guidance will go on to tell you some examples of risks of irreversible harm. So that would include, but not be limited to, things like a threat to patient's life, irreversible harm to patient's physical or mental health, permanent dysfunction of an extremity organ, and risk of cancer metastasis or progression of staging, and finally, risk of rapidly worsening conditions. There's lots of questions that are answered in this guidance document. I'm not going to go forth and answer all of them. I'll give you just some highlights here. There's some questions we've heard about, can I provide vaccination? And our position is that a lack of vaccination poses a risk to the patient and others, and therefore vaccinations are considered essential and should be provided. There's also a question about, can you still see wellness visits? You already heard about making sure we have adequate capacity within our outpatient settings to address the potential surge of COVID-19 patients, and of course the sensitivity to making sure you're not exposing healthy individuals to those who might be there with COVID-19 symptoms. However, the answer to whether you could see patients for wellness visits is yes, if the patient does not require the use of PPE and with appropriate screenings for patients to prevent the spread of disease within your clinical setting. So this executive order does not prohibit that, but you want to be cautious of all the other factors of why you might want to limit those at this time, and certainly make sure you're not exposing well individuals to potentially sick individuals. I think I will leave it at that because there are a lot of other questions that will come forward once this is finalized and posted on the web. Did anybody want to add anything? No. Okay. I will also just mention to you that there is a lot of work happening around surge preparedness in our state. Dr. Jean at the beginning talked about some broad national expectations about the potential impact to the country with regards to this coronavirus or COVID-19. We do have modeling, and we are not going to be sharing those specifics to basically show we expect many more cases over the next couple weeks here in Oregon, particularly in April. I will say that the policies that have been changing regularly that relate to social distancing are critically important to reduce the spread of COVID-19. You know, as you know, there was a new executive order issued by the governor yesterday to further those social distancing requirements, and we just strongly encourage you to take them seriously, to promote them to your patients and your colleagues, as they are important as we try to reduce the impact to our hospitals during the potential surge of COVID-19 patients. There is a lot of work happening in our state across hospitals, organizations, regional preparedness coalitions to prepare for the potential impact of further COVID-19 patients over the coming weeks. These include better processes for collecting PPE and distribution for those in need, also looking into trying to collect the specifications and getting clarity on this, as many industries have been forthcoming offering to create a new PPE. That is still a work in process to make sure that we can clarify what those specifications are to make sure that any new PPE is safe for use. So more to come on that. That is ongoing and being addressed, and many questions coming our way on that. We are working closely again with all the partners I mentioned previously to make sure equipment needs are available, to make sure we are reducing the impacts to our hospitals, to allow hospital beds to be opened up for the most urgent and high-risk patients who need to be addressed in a hospital level setting over these coming weeks, including looking at alternative care sites that we could open up at this time to support those who have lower acuity needs. So there has been the Governor's Joint Task Force specifically looking at surge. The initial report from that task force and recommendations also should be posted no later than today or tomorrow on our website. So that will give you a broader list of all the activities and tasks underway to address and respond to the preparedness for surge capacity. Anybody else to add? Okay. We are almost done here. A couple more, just again to flash up some more important links for you. The first link, one more time, is the Registry of Volunteers that we've mentioned. I still don't have the perfect website up here to get you right to the healthcare providers link. This one here on OHA coronavirus information is the updated, the website with the most updated information on guidance and current status of COVID-19 patients. There is a specific link right on that front page for healthcare providers. When we send these slides out to you, we will update that prior link so you have the one specific to get you to healthcare providers. But it's basically the second link here on this page, but instead of coronavirus, it's coronavirus HCP. And then finally, we have created this email, which we know some of you have used. Outside of the webinar, if you're identifying additional questions that you'd like us to address in a future webinar or informational setting or informational session like this, you can send those questions to this email address. Please do not expect individual responses to your questions. These are intended to be populating our future webinars, and we do not have the capacity to answer every individual or specific question, but we will do our best to answer those topical questions in our future webinars. Also, please do not send any personal health information in this email address. And finally, we are continuing to plan for providing these informational sessions every Tuesday and Thursday from noon to 1. The Tuesday sessions, like today, are going to be hosted here at the Oregon Health Authority as our plan. We will continue to reassess our needs and other partners we can deliver this information with. On Thursdays, these informational sessions are being hosted through the Project Echo tool at OHSU. And that is a session that I'm co-hosting with Dr. Jennifer Vines, the Multnomah County Health Officer, as well as other invited guests. You can find more information on the attached flyer, and as you can see here, the link to the flyer here. We hope you will join us on Thursday. There will likely be a lot of overlapping information, but there will be different guests and different types of questions forthcoming. So we hope that both of these types of sessions are useful to you. I'm looking around the room to see if anybody has any other critical information that we missed today. No? So I want to first say thank you to all the team here in the room at the Oregon Health Authority. We are working incredibly hard to provide efficient and timely information to you, to update our guidelines as new information is forthcoming. Please do look at our website and keep us updated where you're needing more information, for example, through this email address I shared. I also just want to thank all of you. This is an incredibly stressful time for everyone, an incredibly important time for our frontline healthcare providers. So thank you for all that you do, and we look forward to continuing to support you with the information you need to do your work. So with that, we will close out. We are recording this. We had a problem with the recording for last week, so we are working to figure out where we will post this, but we will definitely send out the slides to those registered, the recording, and try to find a place to post that quickly and get that information to you. One more comment from Dr.
Yeah,
Jean.
I just wanted to echo something that Dr. Harganani said and highlight the importance, as healthcare providers, you are trusted authorities for your patients and the public, and I just wanted to highlight the importance of social distancing, because I think that really is the best tool we have at this point. And it's kind of the classic public health or preventive medicine paradox, where the more disruptive the intervention like this, and it is highly disruptive, the better it works, the more it's going to seem like overkill in retrospect, because it's prevention, right? And so it's really important, but it's, we may not see in Oregon, since we've taken these measures earlier in the curve compared to some other states, we actually may see the benefits of it, and we can only really compare that with other areas. But it is the best tool we have, and so I hope you can all model that and highlight the importance of that to your patients.
Great. One more time, I just want to say thank you to all of you working at the front line. Take care of yourself, and we look forward to bringing you ongoing information. Thank you and have a great day.